Hi everybody, Lisa Dada here in El Paso, Texas. Well, here we are, spring 2019. I almost can't believe it. Hope everyone is doing well. I'm going to share with you a very interesting case study of a patient I recently took care of on February 20th, 2019 at the Pediatric Primary Care Clinic that I am precepting at. I will present the reason the patient and family came to the clinic, the patient history, my assessment, and the plan of care. You will see how this one basic clinic visit turned into so much more. VY is a 16-year-old female patient accompanied by her mother who presents to the clinic for her 16-year-old well check visit. VY states she is doing good and has had no recent illness. However, VY does state she has some concerns about increased hair growth and her period. VY and her mother are both the historians during this clinic visit, and both are deemed reliable. Regarding my subjective data and the chief complaint, VY states, I am here for my annual well checkup, but I am also concerned because I have noticed I'm having increased hair growth on my face and stomach. Also, I have not had my period for 7 months, which would have been July 2018. With the history of the presenting illness, VY states she has had a very big year in which she revealed to her mother, family, and friends that she is a transgender male. VY is now identifying herself as a male and prefers to be called JY. He states he has identified as a male since he was a little girl and feels normal as a male. Although JY wants to eventually make a full transition as a male, he denies currently taking any hormones or other medications to alter his appearance. JY and his mother both expressed concern over his increased facial hair, increased hair growth on his abdomen and legs, and no period since July 2018. JY also adds he continues to feel anxious and has difficulty falling asleep at night. Past medical history for JY includes he was born full term with no complications of vaginal delivery, no previous hospitalizations. Regarding his surgical history, no past surgeries. Current medications, JY takes hydroxyzine, 25 milligrams PO, Q6 PRN for increased anxiety. Allergies include no known drug allergies. He denies any food or environmental allergies. Immunizations and health maintenance, JY is up to date. His last well checkup was at 15 years old. Last dental visit was in August 2018. His last eye exam was with his 15-year-old well check. Growth and development, today's weight for JY is 97.3 kilograms or 214.5 pounds. Height is 167.64 centimeters or 5 feet 6 inches. According to the growth chart, JY is in the 93rd percentile for weight and the 75th percentile for height. Development is appropriate with no delays. His speech is clear, no concerns regarding patient's vision or hearing. Nutrition pattern is normal for age. However, JY and mother admit that JY eats a lot of junk food and drinks soda. Mother states it has been a struggle to get JY to eat more fruits and vegetables. JY states he has trouble falling asleep and only averages about 4 to 5 hours of sleep each night. Regarding his family history, mother is 46 years old and denies any medical complications. Father is 48 years old and has a history of diabetes and hypertension. Brother is 26 years old, denies any medical complications. Sister is 24 years old, has a history of asthma. And the maternal grandmother is 64 years old and does have a history of breast cancer. Social history for JY, he lives with his mother and grandmother in a single-level home. Mother and father are divorced. Mother works in a doctor's office and father works for El Paso Natural Gas. The family is covered through private insurance. JY has 2 older siblings, a brother that lives in Austin and a sister that lives in El Paso in an apartment. JY states that his siblings and family are very supportive with his decision. JY is a sophomore at Isleta High School, and he is a member of the wrestling team. Parents have met with the teachers and the principal at JY's school, and they both state that everyone seems very supportive. He denies any bullying. JY states he does have a girlfriend, and they have been together for about a year and a half. He denies being sexually active and is not on any type of birth control. He denies taking any type of hormones. In the review of systems, according to JY and his mother, general assessment, JY denies any recent fever or illness. He has noticed increased hair growth to his face, abdomen, and legs for the past 6 months. He also feels that his voice has deepened. JY's last period was in July 2018. Although he eventually wants to fully transition to a male, JY is concerned why his features seem more masculine without any hormones. Regarding his skin, JY denies any history of rashes or skin abnormalities. However, he does state he has excessive hair growth to his face, abdomen, and bilateral legs times 6 months. Mother states JY's acne has become considerably worse in the last year. Regarding his head, he denies any history of head trauma. Regarding his eyes, he denies any eye discharge, any itching, redness, or excessive watery eyes. He does state he has noticed a slight change in his vision and his eyesight. Regarding his ears, JY denies any ear pain, any drainage, or any hearing loss. Regarding his nose, he denies any sneezing, rhinorrhea, or epistaxis. Regarding his throat, he denies any signs, symptoms of throat pain or complications when swallowing. With his neck, he denies any swelling of the neck. With his cardiovascular, denies any history of heart murmurs, cyanosis, or any other cardiac complications. With his respiratory system, denies any cough, wheezing, or shortness of breath. Regarding gastrointestinal, he denies any vomiting, diarrhea, abdominal pain, states he has regular bowel movements. Regarding his genitourinary system, he denies any previous history of UTIs or complications with urination. States he has not had a period since July 2018 or within the last 7 months. JY states his periods have always been extremely regular and his periods would usually last between 4 and 5 days. His genitalia, he denies any redness, irritation, or vaginal discharge. Regarding his musculoskeletal system, he denies any history of bone fractures or breaks, states he can move all extremities equally without complication. Regarding his neurological system, he denies any neurological abnormalities, no history of seizures, no abnormal twitching, no changes in mental status. Regarding his hematologic system, he denies any previous blood transfusions, no easy bruising, and no history of bleeding. The age of his first menses was at 9 years old, and the last menstrual period again was at the beginning of July 2018. Moving on to the objective data and my physical exam, my general overall assessment, I see JY as a well-nourished, well-developed Hispanic transgender male. He is sitting on the examination table and texting on his cell phone. Mother is sitting on a chair next to the examination table. JY is without any acute distress. He maintains good eye contact and displays a normal affect. JY is well groomed with a masculine appearance and dressed in masculine clothing. Vital signs are as follows: temperature 98.2, heart rate 89, respirations 18, blood pressure 112/75. Today's weight is 97.3 kilograms or 214.5 pounds. Height is 167.6 centimeters or 5 feet 6 inches. BMI is 34.2 and pulse ox is 97% on room air. Regarding his skin assessment, I see that his skin is intact. There's no rashes, no bruising noted to the body. Normal skin turgor. Moderate acne is noted along his forehead, his bilateral facial cheeks, his chin, and back. Hyperpigmentation or acanthosis nigricans is noted on his neck, axilla, and skin folds. Increased male pattern hair growth or hirsutism is noted on his face, abdomen, and legs. Regarding his head, it is normal cephalic and atraumatic. Hair is short and well distributed around his head. Regarding his eyes, conjunctiva is non-injected. The sclera is anictostric. Lids without ptosis, edema, or erythema. Extraocular movements are intact. Pupils are equal, round, and reactive to light. Red reflex is noted bilaterally, and there's no eye drainage noted. Regarding my ENT assessment, he has equal ear shape bilaterally. Right and left tympanic membranes are both shiny and pearly gray with a positive light reflex noted. No drainage is noted from the external ear canals. There is no nasal mucosa. There's no erythema. There's no drainage or upper airway congestion noted. He has a moist oral mucosa. The oropharynx is without redness or exudate. His tonsils are normal in size. Regarding my assessment of his neck, it is supple. There's no pain noted with hyperextension or hyperflexion of the neck. His lymph nodes, there's no tenderness or lymphadenopathy noted. Regarding my assessment of his cardiovascular system, there is a regular rate and rhythm noted. There's normal S1 and S2 sounds. No murmurs, no gallops, no reps noted. Regarding my assessment of his respiratory system, JY has unlabored respirations, symmetric chest expansion, bilateral lung sounds. He is clear to auscultation without wheezing, crackles, rales, or bronchi. No accessory muscle is in use. Regarding my assessment of his abdomen, he has active bowel sounds noted. His abdomen is slightly distended but soft and non-tender. Spleen and liver are non-palpable. There's no vomiting or diarrhea at this time. Regarding his genitourinary assessment, normal external female genitalia is noted, Tanner stage 4. His spine is straight with no lesions. Musculoskeletal system is symmetrical upper and lower extremities with a normal range of motion. Mental status, JY is alert, oriented ×3, and appropriate for age. My neuro exam for JY shows normal reflexes, normal tone, no focal deficits, and he responds appropriately. His vision screening during this well check yields some abnormal results. His right eye is 20/70, his left eye is 20/70, and combined, his vision is 20/50. With the hearing screening that was done during this well check, it yields normal results for both the right and left ear. His TB questionnaire is negative, and the depression screening using the PHQ-9 questionnaire, or the Patient Health Questionnaire 9, has a result of 3, which is within normal limits. So after considering all information gathered from my patient history, the review of systems, and the physical exam, these are the main pertinent positives that coincide with the patient and family's chief complaint, along with other abnormal assessment findings. Number 1, his weight is 97.3 kilograms, or 214.5 pounds. So according to the growth chart, JY is in the 93rd percentile for weight. He has moderate acne noted along the forehead, bilateral facial cheeks, and chin and back. There is hyperpigmentation or acanthosis nigricans noted on the neck, the axilla, and the skin folds. He has an increased male pattern hair growth noted on the face, abdomen, and bilateral legs. He states he has not had a period since July 2018 and is not taking any hormones that would affect this. JY states he continues to feel anxious, something he had mentioned at last year's well check. Hydroxyzine was added to help him with his anxiety. JY states he has difficulty falling asleep at night. His vision screening, right eye is 20/70, left eye is 20/70, and combined 20/50. And then JY states he has had a very big year in which he revealed to his mother, family, and friends that he is a transgender male. He now identifies himself as a male and prefers to be called JY. Therefore, my initial working differentials include polycystic ovary syndrome, pituitary thalamus disorder, type 2 diabetes mellitus, overweight, acanthosis nigricans, transgender, anxiety, difficulty in sleep initiation, and refractive error. My final assessment and diagnoses are as follows. Number 1, well-child examination with abnormal findings, ICD-10 code of Z00.121. Number 2, refractive error, ICD code H52.7. Number 3, overweight, ICD code E66.3. Number 4, acanthosis nigricans, ICD-10 code of L83. Number 5, transgender, ICD code F64.0. Number 6, anxiety with an ICD code of F41.9. Number 7, difficulty in sleep initiation with an ICD code of G47.00. And number 8, risk for polycystic ovary syndrome with an ICD code of E28.2. The pertinent positives from the subjective data that support these assessment findings and diagnoses include, number 1, an increased male pattern hair growth on the face, abdomen, and legs, no menses for 7 months, increased acne within the last 6 months. Number 4, JY revealed to his family and friends that he is a transgender male. Number 5, he states he continues to feel anxiety. And number 6, he states he has trouble falling asleep and only averages 4 to 5 hours of sleep a night. My pertinent positives from the objective data and my assessment and physical exam that support my final assessment and final diagnoses are as follows. Abnormal vision screening, right eye, left eye, and combined, 20/70, 20/70, and 20/50. Today's weight of 97.3 kilograms, and according to the growth chart, he is in the 93rd percentile for weight. Number 3, an increased male pattern hair growth or hirsutism noted on face, abdomen, and legs. A hyperpigmentation of neck, axilla, and skin folds, and moderate acne noted along the forehead, bilateral facial cheeks, chin, and back. So for my plan, first part being the pharmacological interventions, with this well check, we will continue on with the vaccines that are supposed to be administered during the 16-year-old well check. That includes, number one, the meningococcal vaccine, or MCV, 0.5 mLs. We're going to give 0.5 mLs IM times 1 now. And then also the Bexsero vaccine, the meningococcal serogroup B vaccine, 0.5 mLs. We're going to give 0.5 mLs IM times 1 now. The next medication, we will add clonidine, HCI, 0.1 milligram oral tablet. We are going to prescribe that JY is able to take 1 tablet by mouth daily at bedtime as needed for sleeplessness. And then number 3, we're going to recommend that he continue the hydroxyzine 25 milligram oral tablet. He can continue to take 1 tablet by mouth every 6 hours as needed for increased anxiety. Our non-pharmacological interventions include, we are going to discuss the growth curve with the patient and his mother. We want to have him start and implement an exercise program for weight reduction. We want him to implement diet modification. We are going to discuss stress management techniques for him. We will review safe sex practices. And we will do 2 referrals. The first referral will be to Dr. Hector Granados, an endocrinologist here in El Paso, regarding possible polycystic ovarian syndrome, and also the transition to transgender male. The second referral will be to the Counseling Center of Expressive Arts regarding JY's anxiety and also his adjustment reaction with the transition to the transgender male. Outpatient labs that we are recommending for JY, we do want to have a baseline labs that will be ready, so when he does go on his visit with Dr. Granados, they'll have a baseline of his hormones and his thyroid function, all of that. So we are recommending outpatient labs, a CBC, CMP, hemoglobin A1C, fasting insulin, a lipid panel, T4, T3, TSH, serum testosterone levels free and total, LH, FSH, 17-hydroxyprogesterone level, a serum cortisol, and a serum prolactin level. We will follow up and discuss the lab results with the mother in 1 week. And then finally, we are recommending that she follow up at the 17-year-old well check and as needed for any further complications or concerns. Regarding the education for our patient, we are asking and recommending that he start an exercise program to reduce weight and to assist with stress management. We are recommending that he does at least 1 hour of exercise daily. We are discussing with him, we want him to modify his diet. We will be discussing with him on what foods he should be eating and what foods to avoid. We want him to avoid carbohydrates with a high glycemic index, such as unrefined sugars, white breads, potato products, and unrefined corn. We will be recommending that he does increase his intake of foods with a low glycemic index and include foods with higher fiber content, such as whole grain breads, brown rice, non-starchy vegetables. We will review with JY safe sex practices and the risk of STDs and pregnancies. Regarding the outpatient labs, we will make note to the family that it will be fasting. We're recommending that the family and JY can make an appointment for a Saturday morning so that he can be fasting, he won't have to miss school. We are asking that the mother or JY, please call us and leave a message when the labs were done, and that make a follow-up appointment for the lab results in 1 week. We will discuss our recommendation for counseling regarding JY's anxiety and his adjustment to the transition. We are also, we will discuss the referral to Dr. Granados, an endocrinologist, for further treatment recommendations. We will tell them to make an appointment with Dr. Granados after the labs are complete. Further education includes discussing that JY and mother can return to the clinic or to the ER if there's any worsening condition or failure to improve, if there's any suicidal thoughts or ideas, any change in behavior or mental status. And of course, as always, they can follow up as needed. Guidelines for this case study. The management of care for this patient is in accordance with clinical practice guidelines from the American Academy of Pediatrics. Polycystic ovary syndrome is an endocrine disorder characterized by symptoms of obesity, amenorrhea, hirsutism, polycystic ovaries, anovulation, and excessive androgen production. Diagnostic tests include labs such as serum testosterone levels, fasting insulin levels, LH, FSH, TSH, T3, T4, triglyceride levels, cholesterol levels, lipid panel, serum cortisol, and serum prolactin levels. Further testing can include an ultrasound of the ovaries and CT or MRI to visualize the adrenal glands and ovaries. Treatment includes referral to an endocrinologist for possible regulation of menses with oral contraceptives, a reduction of body weight and lifestyle changes, and possible treatment with aldactone, which would regulate androgen receptors. However, in this case, the endocrinologist will also be able to assist JY to fully transition as a transgender male. Follow-up with PCOS includes monitoring for the prevention of long-term health problems such as cardiovascular disease. Regarding my debriefing for this patient case study, this case study and patient presentation obviously was unique. This was actually my first encounter with a transgender patient. I must admit that I was very nervous. I did not want to offend JY or his mother in any way. I will say that when I first went into the examination room, both names were still listed on the patient chart, and I was a bit confused with the female name and the male name in parentheses. I was not sure how I wanted to handle this situation. I wanted to remain respectful, but also be able to collect all the information necessary for me to help make an informed diagnosis. I opted to proceed with my well check as usual and let JY and his mother elaborate during my health history. Once I got the whole backstory, I felt JY and his mother felt very comfortable in telling me not only about his medical concerns, but also about all his psychosocial concerns. Wanted to add, I was fortunate enough to attend the Interdisciplinary Experience Workshop held at UTEP this past Friday. It was a mix of different disciplines from UTEP taking part in a case study evaluation. The different disciplines included medical students, pharmacy students, speech therapy, OT, PT, social work, and nursing. We were placed in groups asked to assess and treat a patient from a specific case study. The whole lecture was about treating transgender patients, and it was very enlightening. We had a guest speaker who was transgender and spoke about his experiences in healthcare. We learned how the different disciplines could be utilized to offer the most respectful and appropriate care to these types of patients. And we were given resources available in the community that specialize in treating these special patients. In the end, I think I was able to make JY and his mother feel very comfortable and respected. As a result, I also became more at ease and comfortable that I was not going to offend JY. I think the treatment plan we developed was appropriate and practical for JY and the family. I do think that all the interventions in our plan addressed his concerns and offered a possible solution for improvement. I think JY will respond appropriately and favorably to his treatment plan. This concludes my presentation. I hope all this information was to some use for you in the future. Thank you. Bye-bye.